speaker for tonight, Dr. Jackie Pollock. Dr. Pollock is a senior career medical officer in community and developmental paediatric and Sydney local health district. Outside work, Dr. Pollock is a keen clarinet player and is a member of the NSE Doctors Orchestra since when it started 12 years ago. Thank you, Dr. Pollock. Over to you.
Thank you, Lydia, and welcome to all those who are watching this webinar. I have to admit it's a little bit disconcerting sitting here looking like I'm talking to myself, but I know you're all out there. I'm hoping some of you might be a little bit familiar with our department, or even me, or having seen my name on reports because I've been around for quite a long time. So I'm talking about paediatric developmental delay tonight, how to recognise it, developmental screening tools, and a range of other things. I've had a list of questions submitted to me prior to this presentation about things that GPs have wanted answered or addressed from Margot Woods. So I've tried to incorporate some of those topics in this presentation tonight, and I hope that's what you might be wanting to cover. And if not, I hope to be able to answer any questions. So paediatric development affects all children, and it is just that. Development is something that develops, and therein lies the trickiness sometimes of recognising developmental problems and developmental delay. Why is development so important? The first 5 years of life are absolutely critical for physical, cognitive, social and emotional health, and early life experiences are strongly predictive of school performance, involvement in the criminal justice system, even obesity and learning difficulties. I probably won't even start here about the effect of the 2-year COVID lockdown essentially on children's learning, but it actually has been quite profound. There's children in disadvantaged situations who have essentially lost 2 years of their critical schooling on top of some adverse early childhood experiences. So just looking at the terminology of paediatric developmental screening or checking development, there are 3 separate sections of it really. So the first thing is developmental surveillance, which is the process, an ongoing process of recognising children who might be at risk of developmental disorders or developmental delay. And I'll talk a little bit more about that as the slides go on. Screening is the actual use of a standardised tool to try and identify that developmental risk at a particular point in time. One developmental screen on one date is really needs to be taken into context with the whole psychosocial background of the family, and perhaps seeing that child again and doing another screening test. And following that, we've got once a developmental delay has been identified, referral and further evaluation, which can be quite a complex process aimed at identifying formal global developmental delays or intellectual disability or autism. Seem to be the 3 most common things that we see. I'm sure everybody knows this. I won't go detail through this slide, but childhood development is just the progressive acquisition of skills as a child matures and grows, and it's actually a complex process. It's like a growth centile chart. It doesn't go in a smooth line, and there's spurts and plateaus. Development in different areas develops at different rates. There's a different trajectory of development in boys and girls, and psychosocial and adverse childhood experiences early in life can affect development as well. So there's a lot of confounders. So the developmental domains that we are looking at are usually gross motor skills, sitting, crawling, walking, jumping, fine motor skills, hand use, building blocks, puzzles, visuospatial tasks, language, which is probably the most significant and the first one that comes certainly the first thing that's usually identified is a language delay. So there's expressive language, which is looking at what they're saying or babbling. There's receptive language, with looking at what children are understanding. And look, there is one thing missing in there, if you want to take a note. It's what we call, the third thing is what we call social pragmatic use of language. So the way we use language to communicate in a social situation. And there's personal, social and self-care skills, which are the activities of daily living, like feeding, dressing, that kind of thing. Why does the developmental delay happen? It can be a biological factor, such as a medical illness or a chromosomal disorder, environmental factors, such as maternal mental health, marginalised families, but probably vastly the most common is an unknown etiology. After we've done all the blood tests and everything else, there's no specific cause that we can find. So it's a complex process of working out why children are developing at slower rates than others. As I've just said before, it's a flexible, continuous process. And this is for developmental surveillance. And essentially, each visit to the GP should be seen as an opportunity to review a child's health, development and behaviour. And I know this is extremely easy for me to sit here and say that to GPs who are super, super busy and have a myriad of other things that need to be done. And often a child comes to the GP for a problem or an illness. So it is hard to keep that in context. We often recommend that the immunisation visit is a really good time to do developmental surveillance. A screening assessment. So a screen is a brief assessment procedure designed to identify children who should receive a more formal assessment. And it should be something simple, easily available, easily reproducible, with a high sensitivity and a high specificity. Always hard to get those things right. So the definition of developmental delay, which was one of the questions that was asked to be addressed in this presentation. So developmental delay is essentially a child who's not developing skills according to the expected time frame under the age of 5 years. And a specific developmental delay is a delay confined just to one area of development. A diagnosis of global developmental delay, which everyone's probably heard of, according to the DSM-5 book, is for children under the age of 5. You don't need a formal assessment. It's where you can make a diagnosis where a child from history and observation fails to meet expected milestones in several areas of development, and that usually means 2 or more. These children don't have to have any form of standardised testing to receive this diagnosis. And it's recommended that these children are reassessed when they're closer to 5. And it's a clinical diagnosis, as I've just said before. We've really been through that one, how important early identification is to the wellbeing of children. And done that one as well. Please don't forget hearing, vision and social and environmental factors. So when you're doing your opportunistic developmental surveillance or developmental screening, which we'll get to in a moment, don't forget hearing and vision. They're vital senses for children. A main red flag for developmental assessment or developmental referral is any regression of skills. So the screening and surveillance tools, which I've been asked about before. So there's many, and there's no one definitive one that you must use. People use a range of things. So I've just put up the most common ones, or certainly the things that I found most helpful. And probably the most helpful is a good history from a parent. So if you can get a good history, if a parent is worried, that equation usually equals there's probably a problem. So if you get a good history from a parent, and if you don't have time in a brief appointment, it would be advisable to make a longer appointment. So history from parent and informal observation of the child. I'll have a case history a little bit later. The main one everybody knows, I'm sure, is the Blue Book. So the developmental milestones are in the Blue Book, and hopefully parents might come to you having gone through that Blue Book and feeling that their children are not making the progress that is expected of their age. There's the Ages and Stages Questionnaire, or the ASQ, which I'll talk about in a minute, and is something that's on the Health Pathways site. And I'm just putting this here. It's not on the Health Pathways site. It's a small, thin paperback book by Mary Sheridan called From Birth to 5 Years. It is not a new book, but it's really a timeless reference. And I can tell you that after 30 years in child development, I still carry it around in my little bag. It's a really wonderful book to refer to. You can get it from any shop or book depository, etc. So I'm sure everyone's familiar with the Blue Book, and there are milestone pages right throughout the Blue Book for different ages. I'm sure everyone's familiar with all those age points in the Blue Book. Which brings us to the Ages and Stages Questionnaire, which I've been asked about as it is on Health Pathways. So one of the things I've been asked is, where do you get it? And I did have to look this up because I'm just in a department that already has it, so I'm not really involved in buying it. So you do have to buy it. It is not free. Once you have bought it, it's a set of questionnaires, and there's a little bag of equipment that's optional, but the set of questionnaires, you have to actually buy that. Once you've bought it, you are allowed to photocopy it, I think by copyright. So you purchase it from Brooks Publishing in the USA, but I've seen that you can buy it on other online bookstores such as Booktopia. The Jimmy's website seem to have it, and the Book Depository as well. So it's a series of parent and caregiver questionnaires. So the questionnaires are self-report from the parent, or you go through the questionnaire with the parent. So you can give the questionnaire to the parent to complete and come back to the clinic, or you can do it with them. There's 19 questionnaires for use at all different ages. So there's a questionnaire for a 2-month-old child, a 4-month-old child, and so on and so forth until the age of 5 and a half. Sorry about that. All the questions cover all the developmental areas. And this is what it looks like, just to give you a little, for those who don't know. So there's 5 different areas of development, and there's 6 questions per area. It's really easy to use. If you've never seen it before, I suppose it just looks a little bit confronting here, but it's really simple questions. It's do they do it yes, sometimes, or not yet. Not yet gets 0, sometimes gets 5 as a score, and yes gets a 10. And you add up a total out of 60 for each developmental domain. And then you can score it up. There's a little table at the back of the questionnaire, and when you score it up, it gives you a cut-off. But essentially anything in the black area means they've got there is a significant developmental concern, and they should be referred. The grey area is where you just need to monitor those skills. It's fine for them to come back again. There's the Ages and Stages Social Emotional Questionnaire to assess children's behaviour and emotional well-being. I have to be honest and say I am familiar with it. We don't use this a lot. It's something like 50 questions, so it's quite a lot of questions. Takes longer to do, and families have to have quite a good degree of literacy to do it. I generally just take my own history about behaviour, but it definitely is out there. That's kind of what it looks like. There is a bag of toys, and I actually, if you're going to buy this questionnaire set, I highly recommend that you get the little bag of tricks. It's a ridiculous price of about $300 for just these little toys, but it's a one-off cost, and it means that you can actually do these. Do some of these questionnaires, some of these questions with the child in your surgery. Sometimes parents have never done the things that the questions ask. And that's the cover of that little book that I was recommending. What do we do? If there's a concern in one domain, we recommend a full history and medical examination. we'd refer to the relevant allied health therapist. So if it's a delay in gross motor skills, refer to a physiotherapist, or a speech therapist. A speech delay should always trigger a hearing test, as well as a speech pathology referral. And speech, occupational therapy, and physiotherapy and behaviour support is all available through, so speaking for Sydney Local Health District, is all available through our community health department, and you can refer there. There are waiting lists, or otherwise refer privately. If there's concern in more than one domain, these are the things we recommend in addition to a physical examination, obviously. So we would recommend hearing and vision testing. We'd recommend referral to the relevant speech physiotherapist or allied health therapist. We would recommend a referral to your local early childhood, early intervention service provider, which in my area is Lifestart, but I believe it's an organisation called EACH in the eastern area. I would probably recommend referral to a paediatrician or a community paediatrics department, and you can make all these referrals simultaneously. That was a question that was put to me before this presentation, and it's a really great help to us if all of those things have been done or have been put in place. They don't necessarily all happen at the same time. The early childhood, early intervention can take quite a while. The ECEI supports children 0 to 6 with developmental delay or disability. You don't need a formal diagnosis, so you can make that referral straight away. I've popped those numbers on the slide there. They are part of the NDIS, so I've just put the NDIS's main number there, and I'm sure you're all familiar with that. Another question that was put to me is blood tests, and should GPs be doing the range of developmental blood tests and investigations? It's not been my experience that GPs do all the investigations before they come to us, nor do I believe it's your role to do that. So we would really only recommend nutritional and general blood tests if children have really poor diets, which many of them have. There's a very high incidence of iron deficiency. Children who are on the autism spectrum have really poor diets. Genetic testing is usually ordered by the paediatrician once there's a confirmed diagnosis of global developmental delay from a formal assessment and or autism. There's no reason why a GP can't do all the genetic testing, but I don't think it's necessary. I think that's something that certainly the paediatrician can do themselves. So the usual blood tests that we order for a confirmed developmental diagnosis or autism are just these listed here. I've never found an abnormal urine metabolic screen ever. There's a variable yield from the investigations. 40% of children with a moderate to severe intellectual disability won't have anything. And 70% of children with a mild intellectual disability won't have anything. The most common thing we find is a thing called the BOOS, the variant of uncertain significance, where they have found a minor chromosomal deletion whose significance for pathogenic disease is not known, and sometimes it's familial. Essentially, what most general and even ourselves in community paediatrics do, if there is a genetic disorder or a chromosome defect, we are actually refer on to the public genetics clinics or to a private geneticist for further consultation and counselling. Just popping in a few red flags here for autism. It is such a common thing, and I'm sure you all see it, and it is the thing that parents are very worried about often. So it's impairments in social interaction, so poor eye contact, poor sharing of enjoyment, no response to name, odd tone of voice, restricted and repetitive behaviours and interests, and a regression of developmental skills. So a regression occurs in about 20% of children who eventually are diagnosed with autism. I'm sure everyone's familiar with those things. These are just some absolute indicators for referral of preschoolers for an autism assessment. I'm popping that here there because this is another issue that was raised for this presentation. So no babbling, no single words by 18 months for language, social communication, no sharing of interests, no interest in playing with other kids, and a whole range of restricted and repetitive body movements and habits. There's a lot of what we call food rigidities as well. We watch for social skills. Pointing is a really important thing to ask parents about. Not just pointing to show what they want, but pointing to request, pointing to show something to their parent. It's really quite a strong red flag for a developmental or autism problem. Children with autism and communication difficulties have delayed language. They echo phrases. They recite phrases and dialogues from television, or I should say YouTube videos, and they have an unusual voice quality often. They used to be obsessed with Thomas the Tank Engine. I believe that's now gone out of favour, and there's Peppa Pig has taken its place. Children with autism who have significant obsessions often move on. One obsession goes away and another one takes over. And there's generally a lack of symbolic or imaginative play. Just a case study here. And this would be fairly typical and probably one of many that walked into your surgeries. James is 2.5 years old and his parents are concerned that he's different to other children in his month's group. He doesn't respond to his name being called. He always seems to be in his own world and spends hours in the sandpit or playing with water. His speech appeared normal in his early months, but then he stopped talking in the second year of life. It's typically between 15 to 18 months of age, and he now has only a few words. So that would be a fairly typical presentation. So that would be of autism, but we're just going to move on to, I guess, what we do at our end when we receive a referral for a developmental delay in 2 or more areas or query about autism. So we just do a full medical history with a full systems review. We have the absolute luxury of 1 hour for an initial assessment in our general paediatric clinics, and if they're referred on to our full developmental assessment clinic, we have a 3-hour session. It's often not that long, but we're very lucky to have that. So we make sure their hearing and vision are done. We get a feeding history, history of their sleep, and a detailed developmental history, and all the usuals, whether they're on medication, just their general health. We would do a general observation of the child, just an informal observation of the child in our office. And for James, the case I just presented, this would be fairly typical. He would still be in nappies. They're often got a bottle in their mouth because it's soothing and comforting. Once the bottle's out of their mouth, they're usually mouthing other toys. They have repetitive play, such as lining toys up. Often flap their hands when excited, usually very, very active and often destroy your office, as has just happened to me at 4 o'clock this afternoon. Very much their own agenda of play. Do a full physical examination. We always just check their skin. I've actually found more than one on Recklinghausen's disease just by looking in the axillae. These are the investigations and assessments that we would do once we've established that there is a definite problem. So hearing and vision, if it's not already been done, we would ask for speech and occupational therapy assessments. We would do our blood tests. Something that's really vital, that's really helpful for GPs as well, is to get some written feedback from their preschool or childcare. We actually have a standard skills questionnaire that we send out. Sometimes when in our initial appointment, if children haven't had a formal screen, we will do an ASQ. So the ages and stages questionnaire is the screening tool that we use. there are some screening questionnaires called autism rating scales. They're used very frequently in schools by teachers, but we don't use those. Once we progress to developmental assessment, which is the full developmental assessment in the 3-hour time slot, we often use a tool called the Griffiths Scales of Development for children under 5, and it assesses development in all the different areas with a whole range of little items such as puzzles, blocks, threading beads, cutting paper, drawing, stamping, language questions. It takes quite a while to do, and we are informally observing social interaction. So autism behaviours are not tested for, but we're making our own informal observations. That is what the Griffiths kit looks like. So there's blocks and puzzles, all the things I just told you about. For some children, we can't, I'll just go back. For some children, so usually at the developmental assessment, we can probably more often than not make an autism diagnosis as well as a developmental delay diagnosis, really based on the feedback that we've got from the preschool and the history that we've got from the parent and our own observations of that child's behaviour and interactions. An autism diagnosis, just like a global developmental delay diagnosis, is a descriptive diagnosis from the DSM-5 book. There is no blood test or official testing tool that you need to use. If we can't make the diagnosis, then if we still have quite strong suspicion, you can have an autism-specific assessment, which we do. These are a whole range of toys and tasks that we don't test to see whether children can complete the puzzle, but what we're looking for is how the children play with these toys, how they interact, how they use their language. We observe for repetitive behaviours and rigidities, and it's a scored test. That gives us another tool to give us more information. I've just spoken about that. So DSM-5 is the gold standard for diagnosis of autism spectrum, also for global developmental delay as well. A diagnosis of global developmental delay can only be made under the age of 5. This was another question that had been put to me. I guess what's next after a diagnosis? A lot of this applies to developmental delay as well. So there's really no, I wish I had a magic wand, but there's no magic cure or treatment. So it is autism specific or developmental delay specific early intervention of all the allied health therapies, behaviour support, and supporting communication, particularly with the use of visual strategies. This is the HEX system. I'm sure some of you have seen this, where children have these little pictures all cut up and on a key ring. There's now an electronic, there's a few electronic programs now for communication. One's called Prologo to Go, and the other one is called the LAMP program. There's no specific medication to treat the core impairments of autism or even the core impairments of the behavioural difficulties that arise out of global developmental delay. Medication's got a discrete but important role in the treatment of targeted symptoms, and it's always got to be combined with a behaviour plan. I'm sure all of you are extremely familiar with these. These are some of the medications that are used to address problem behaviours. I might add, in the preschool years, I don't think any of either myself or any of my paediatrician colleagues would use any of these medications under 5 without consulting a child psychiatrist, which we have access to for consultation, and it would be very rare that we would use any of these under 5. So stimulant medication is used for attention and hyperactivity, risperidone for irritability and aggression, SSRIs for anxiety, and clonidine is used for sleeping. It's also used for disruptive behaviours as well. The aims of our diagnostic assessment, just to summarise, It's really is to identify and describe the difficulties, try to work out what other contributing conditions may be important in this child, such as vulnerability, neglect, all those things that we see, all the psychosocial difficulties that families have, children in out-of-home care. It's a real conundrum, and I can assure you it perplexes us as well, and we don't always have the answers. Children who've been subjected to severe neglect and emotional abuse can present with autism or developmental delay behaviours, and it can be very difficult to tease that out, and they're not mutually exclusive. So you can have a developmental delay and autism and have the behaviours that trauma elicits. So our aim is to communicate the findings to the family and set up an intervention plan which is appropriate for each child and family, and provide ongoing support and information. Just the team members who are usually in our multidisciplinary team are just listed here. We don't have all of them all of the time. So we usually have a psychologist assisting us, and the speech pathologist, all the others come in and out as needed. Just some additional investigations which we sometimes consider, but I think that's our problem, not yours. A quick overview, I'm just mindful of the time here, of intellectual disability assessment. So intellectual disability is a diagnosis that is made after the age of 5. These are the kinds of tools that are used, and only a psychologist can do these, so I'm not doing them. Just a quick bell curve to show, I guess we are showing this to families often, just to give families a little picture of where their children lie in the terms. This does apply in general to our developmental assessment as well. So essentially children who are scoring below two standard deviations below the mean, which is under 70, which is less than the second percentile, are those children who would have a global developmental delay. But this picture seems to communicate the words a little bit better to families. So just in summary, early detection is important. Screening is part of a longitudinal surveillance process that involves responding to parental concerns and sometimes trying to elicit them when you observe obvious developmental problems in your surgery. And screening is a component of surveillance, and it acts as a platform to provide advice. So screening is when you're looking at development at one point of time, and surveillance is just that ongoing checking of how kids are going. Oops. And we see our role as just engaging dialogue with parents about their health and development, and providing referrals for further assessment and information. We try to focus, having spoken about all those things, it does sound like we're focusing on children's deficits, and to an extent we are, because that's why they're coming to see us. We do try to look at the whole child and highlight their strengths, and their strengths are as important as weaknesses, and I really mean that. So many children with autism have wonderful skills in reading letters and reading words, frankly. So there's a lot of ways that can be put to good use to help them at school. They learn visually rather than from an auditory perspective. And that's probably all I have to say. Thank you very much for listening. It's been difficult not being able to see anybody, but I know you're all there. Thank you very much.
Thank you, Dr. Pollock. We have no questions at this point, but I believe there will be questions coming through. Also, you have mentioned at the beginning that you have received some questions via email before the event.
I'm sorry. So it was not, it was, so Margot Dr. Margot Woods, I believe, who was a facilitator but couldn't be present tonight, did send me a list of sort of 7 things that she felt would be helpful to cover, because these are the things that GPs have wanted to know. So, yeah. I'm not sure if that they're her questions, or they're a compilation of the things that she has gathered from other GPs or informally. So rather than just go through them.
Right,
so
thank you.
Yep.
There is first question in Q&A box. If there are any differences in early diagnosis for girls versus boys?
Oh, it's a really good question. I'm not quite sure what you mean by different. So developmental delay problems and autism problems are 4 times as common in boys. So we see a lot more boys than girls. When girls have a developmental delay, it seems to be a more severe developmental delay than boys. There's no difference in terms of approaching it or assessing it. Girls do tend to have earlier development of language, but certainly not significantly so that there would be different milestones for language development for girls. So we approach it at the same, but we certainly see less girls.
Thank you, Jackie. The next question, how can we support families to understand the wait lists for developmental assessments?
So I would probably suggest supporting the family by making a referral to the early childhood early intervention. That actually has been a game changer for us, because at least we know that the children are getting some support. In terms of supporting the family, I think you are certainly able to reassure a family that they are getting the intervention that they will probably be getting anyway, even if they had their developmental assessment, next week. The intervention will still be the allied health interventions that they need, the hearing and vision assessment. So all of that can happen. Under the age of 5, you don't need any formal diagnosis. And frankly, a GP can call it global developmental delay. You just have to be able to say from your history or from a screening, you don't have to have one of those things. You can take a history, you are able to state that they have a delay in 2 or more areas and they have a global developmental delay, and that will make them eligible to get early childhood early intervention. Unfortunately, I believe there's a waiting list for that as well at the moment, but yeah.
Thank you, Dr. Jackie Pollock. We don't have questions at this point, but please stay with us if time allows.
Thank you, I will.
We'll come back to the questions as they come through. And I would like to introduce our next speaker for tonight, Dr. Martina Gleeson, Sutherland Shire GP, Clinical Lead General Practice, Southeastern Sydney, Health Pathways, and Regional Clinical Advisor, Health Pathways in New South Wales. Thank you, Dr. Gleeson.
Hi, Lydia, and hello, everybody. I might just ask Jackie to stop sharing her screen so that I can share mine.
Yeah. And how do I do that, Lydia? Oh, there we go. I've got it.
Thank you very
Martina,
much.
is that okay?
Yes, that's perfect. Thanks very much. And I'll just start sharing mine, and hopefully we will get it. Trying to get it onto the full screen. There we go. So I'm going to talk to you tonight about how to use health pathways in this process of developmental assessment of children and accessing support for them. So I'm speaking on behalf of both of our PHN Health Pathways teams, Sydney Health Pathways and South Eastern Sydney Health Pathways, and I'm hoping that many of you are familiar with us and probably already have a login, but if you don't, if you point your camera at the QR code, it will take you to the website, and then you can use the login details on this slide to log in. For the last year or so, because we're the same PHN, we've decided to cooperate, and so you can use your Sydney login for South Eastern Sydney Health Pathways, and you can use your South Eastern Sydney login for Sydney Health Pathways. So you're very lucky because you have access to 2 sets of pathways for the price of one. All right. So, and just another little tip when you're using health pathways and you're looking for something and you're not quite sure where to look. One way you can do it is to go up into the top of the screen and type in the word to search for using the search bar. We have used sotrovimab as an example in this, but you could just as easily search developmental. And then if you type in sotrovimab as an example, pathways that have mentioned that come up in the search box, and so you choose the relevant pathway. And then if you click on the little expand all box, which is either on the top right hand side or right down the bottom of the pathway, depending on which version you're looking at, you press Control F and type in the word to search for. Then the up and down arrows will help you find the bit that you're looking for. And that's for all pathways. That's just a basic word thing, but it works in our pathways to help you find what you're looking for. Just to give you an idea of the sorts of pathways that we have on both sites that are relevant to tonight's topic. Southeastern Sydney has got pathways on milestones, acute otitis media, hearing impairment in children, paediatric developmental assessment, child and family community support, and early childhood support. And we've also got allied health paediatric pathways on audiology, speech pathology, occupational therapy, and the NDIS, which also helps you access that early childhood intervention funding for your patients with developmental delay. And it's got a lot of detail on that, on how to do that. And in Southeastern Sydney, we also have developmental concerns in preschoolers, behavioural concerns in children, healthy child checks, paediatric physiotherapy and dietitian services for children, imminently going live, which will be very exciting for us. Sydney has these same milestones and some extras: developmental concerns in young children, milestones, healthy child checks, speech and language difficulties in children, autism spectrum disorder, child and family community support, child health requests, and also allied health, speech pathology, occupational therapy, physiotherapy, psychology, and early intervention services through NDIS. So fairly similar, and that's helpful. I thought I would take a chance now to just demonstrate some health pathways so that you get an idea of where you might use them during a consultation. So I'm just going to stop sharing so that then I can select a different screen to share. And while I'm doing that, Lydia, are there any questions that are coming in already?
Thank you, Martina. There is one question on the password for the health pathways, but it's coming, I believe, in the future notes.
It was on the second slide, but when I finish doing the demonstration, I'm very happy to go back so that people can take a photo of that slide to remind them what the passwords are.
Thank you.
All right, so this is, for some reason I'm in the Sydney draft, but that's all right. It's the draft and the live are the same for both of them. So this is the developmental concerns in young children pathway. And if you're not familiar with health pathways, they have a fairly standard construction. So if there are red flags to think about, then they'll be up the top. We try not to have red flags too often, but obviously areas where you might find particular difficulty in developmental concerns would be if there's significant impairment or delay across 2 or more developmental domains, or if there's regression, or obviously if there's a complex psychosocial situation. And then as you go down in a health pathway, you'll find a little bit about, and it's worthwhile having a look at that the first time you open a pathway if you've got time. And sometimes we have a practice point, like if the parents are concerned, listen to them. And then it will take you down through the assessment and the management. And the thing that makes health pathways unique, as you would know, is that we also identify the local services to help you find your local community paediatrics team, how to refer to your local speech therapy team. And that's something that you're not going to find on something like therapeutic guidelines. There was a question about ages and stages questionnaire, and I'll get to that in a minute, but we do want to make a note that if you're actually going to do a developmental assessment, you might flag it in a consultation, but you're probably not going to do it in that consultation, but bring the parent back to assess the child a little bit more. So arrange adequate time, play equipment available. And it's helpful to get the parent to bring in the blue book, because it's got the milestones in the blue book. If you don't have the blue book, there is actually a health pathway called Milestones, and it links to the Learn the Signs Act Early pages from the New South Wales Health, and it also links to the Centre for Disease Control fact sheets on developmental milestones. So coming back to our pathway, I'll get down to the there are some alternatives there for you, and there's actually a milestone tracking app. So if you've done a bit of an assessment and the child's not quite meeting milestones, but they're kind of in the grey zone, and you decide to track them for the next couple of months, they can use the milestone tracking app to give them an idea, which they can download onto their phone and use. There was a question about the ages and stages. I know it's in here somewhere. I've just got to remember where it is. Here we go. In the perform testing drop down, it links to the ages and stages questionnaire that Jackie demonstrated. And you can pay for a subscription to get it online, but it can be accessed free by clicking on this link. I think you might have to register with Easter Seals, and the report isn't available immediately, but it is it's a lot cheaper to use for your patients than actually registering to use it yourself, unless you have a particular interest and you do a lot of developmental assessments. And the other thing to do is to refer the family to the early childhood nurse, because they're trained in the ages and stages questionnaire, and they also have access to it through the health department, so they don't have to pay for it like we would have to as individual practitioners. And then the early childhood nurses will also be able to help the family access services through the local health district as appropriate. So that can be a good way to get the assessment rolling. Then going down through the management, it addresses some of the things that might not occur to you, like childhood neglect or abuse, and what to do if there's actually been a regression. And urgent paediatric assessment actually often means sending the child off to the emergency department if it really has been a significant regression, because maybe there's something medically going on. And yeah, just really encouraging you to think across the domains that Jackie was talking about today. But as you can see, a lot of what she was talking about in her talk is covered in the health pathway, including talking about if there's a delay across 2 domains or a strong suspicion of autism disorder, a list of the appropriate referrals. Whereas if it's an isolated developmental delay, involving allied health initially, and possibly even a GP mental health treatment plan if it's appropriate for psychology, and more particularly for occupational therapy. And each of those blue things means that you'll link to a relevant health pathway that will show you the resources available in your community to help you access them, hopefully both private and public. And then down into the request page, it basically summarises what's already in the management section for where to refer. So sometimes with a health pathway, you might already have done the assessment, you might already have a management plan, but you want to log into the health pathway to access how do I get, where do I go to from here? And so you might end up going on to the developmental concerns in young children pathway, for example, and scrolling right down to request, because you know what you want to do. You just want to be able to link to the right place in your local district, whether that's Southeastern Sydney or Sydney. So, and there you've got links to all of those services that help you to access them. Don't forget, on health pathways, sometimes there's a little bit extra down in the information section, both for health professionals and also for patients, which can really be helpful. Sometimes it's really nice to give the parent a piece of paper that summarises some of what you've done, or gives them some thinking time, or time to read and think through things. All right, so that's demonstrating that particular pathway. If I was to click on, say, speech pathology here in the Sydney pathway, then you would see that they've said there's no public speech pathology services in the Sydney Local Health District for patients ages 13 to 17. But then you'll find what the criteria are for a referral to speech pathology in the public system, what information you need to send, and the contact details for the provider and where you can access them. So that can be really helpful. And then also sometimes because things change so much in the private system, we might use a directory, especially if there's a directory that's quite good. So that will take you to an external directory where you can find a speech pathologist in your local area. And also a reminder that it might be appropriate to use a GP management plan and team care arrangement to help people access some Medicare rebates for some of the initial sessions they have with allied health. So that's the sort of thing that pathways can help you with, not just the assessment, not just what do I do now, but who can help me now. And I think that's the big thing that we find helpful with health pathways. I thought at this stage we might actually think about a case study, but I can see that there are some questions. So Lydia, would you mind reading them out for me while I access the PowerPoint again?
Thank you, Martina. And I've put the passwords into the answer. So
thank you.
Now.
Thanks very much. Yeah.
And Jackie, if you'd like to put your camera back on, once you're not sharing your screen, it should be all right now, hopefully. Thank you. So the first question we have, is there a role for practice nurses to assist with milestone screening, especially that general practitioners are so busy at the moment? I mean, always.
Yeah, I would think that there is, especially if the practice nurse is trained in doing the developmental screening. And if my practice has a lot of elderly patients, so we probably wouldn't invest in the ages and stages questionnaire, but if you've got a practice with a lot of children and you've got a big interest in that, I would think it would be quite appropriate for your nurse to do the training and to assist with some of that assessment. What do you think, Jackie?
Yes, I'm really sorry that I omitted to mention the early childhood nursing service, which is so important. I think I was just thinking of GPs, and our service, and I missed that bit in the middle. So thank you so much for highlighting it. And it is their absolute specialty to look at children. They do the ASQ questionnaires all the time. They've got the time to do it, and they can do home visits as well. So,
and with your practice nurses, often they have the benefit of they're seeing, like our practice nurses do a lot of the immunisations. And sometimes parents just book for the immunisation and they don't necessarily book a developmental check with the doctor. And so it's really helpful if the practice nurse is tuned in to the child's behaviour and can pick up subtleties and recommend, I think maybe it would be a good idea for you to see the doctor to give the child a checkup as well. So
I think the practice nurse, well, I know the practice nurse could do the ASQ.
Yeah.
So that it's sort of that bit's done.
Mm-hmm.
And then the doctor just has to see the child, and the sort of that little semi-formal screening bit has been done. So I think it's a great idea.
Another question, Lydia?
Thank you. The next one, what processes can be implemented in general practice to flag milestones monitoring? Immunization screening doesn't include screening between 18 months and 4 years.
That's right. I was thinking that. And I think really it's reasonable to say to the parents, it would be good to have a checkup of your child with each birthday at the very least. So, and bring them in for a growth and development review. So weight and height and developmental milestones. I think we also have to be opportunistically checking kids out whenever they present to the practice. Some children are amazingly healthy, especially now that they're all immunised against Haemophilus influenza B and pneumococcus, and we don't see as many otitis media as I saw in the beginning of my career. So we sometimes miss those opportunities. So every time, and of course now with COVID, we're not seeing that many people with OTIs because we're trying to manage them without bringing potentially infectious people into the practice. So we really do need to take advantage of every opportunity, even if the child's not the patient. You know, casting an eye over the child that's in the room when the parent is the patient, and just paying a little bit of attention and asking a few questions. How are their words going? You know, are they speaking in sentences? Can other people understand them? Watching how they play with things in the practice, and then flagging, I'd like to have another look at this child. Could you bring them back in? So I think we just have to take advantage of every opportunity, but we can be proactive, and you could certainly, there would be nothing stopping you putting in a recall for the child for them to come back around their second birthday and their third birthday, so that you can do a review.
And the Early Childhood Nursing Service does try to actively promote the children coming in at every birthday as well. But it's a really good question. There's just a huge gap between the 18 months. So much can happen between 18 months and 4. That's actually when it all happens.
Absolutely. Yeah. Any other questions?
There is more a case presentation. My 3 years old patient had global developmental delay. She saw 3 different pediatricians, including 2 developmental specialists. No one suggested any medical tests, just clinical assessments. She was eventually 2 years later diagnosed with a rare disorder by her urine metabolic screen. Not to be dismissive of this test, she had a treatable disorder and is now developing normally, but with some permanent damage from the delayed diagnosis. Please remember, some developmental disorders are treatable, but only if diagnosed by medical tests. I guess I would just ask for your opinions, please.
Okay, it's really difficult to comment on a condition. I'm sorry, Lydia, some of the audio has dropped out as well. So I hope I heard all of the question correctly. She saw 2 different pediatricians, and what happened after that?
She saw 3 different pediatricians, including 2 developmental specialists.
Right, okay.
No one suggested any medical tests, just clinical assessments. She was eventually 2 years later diagnosed with the rare disorder via her urine metabolic screen.
Yep. Okay. Thank you. I heard all that. It's just very hard for me to comment on that. I know essentially if any of our children have a confirmed global developmental delay, and I guess that would be on tertiary testing on the formal developmental assessment where we're doing a Griffiths. So that is an outcome that's below two standard deviations below the mean. We would be ordering all those blood tests. So it's always easy in hindsight. It's incredibly rare to find anything on a urine metabolic screen. But I guess this is the time, but it does happen, and unfortunately this is the child it happened to. But we always, the urine metabolic screen is always ordered along with all the other blood tests. We never not order it because it's nearly always normal. So yeah, it's just unfortunate. I'm sorry.
So Jackie, can I ask, because I looked and it's not in the health pathway, the urine metabolic screen, or those other blood tests are. So thank you to our participant for asking that question.
Yep.
But is it something that you would expect a GP to order the blood tests and the urine metabolic screen, or is it something that you really think is in the realm of the paediatrician when they are assessing the child?
So Martina, I think absolutely the latter. I just think GPs deserve medals. I couldn't imagine doing what you do, and I think it is definitely the paediatrician or the community paediatric department's role to order those tests. The only test I'd suggest is it's really worthwhile doing a dietary history for kids with developmental problems, and you'll often find that they're on the white diet, so it's chips, milk, no meat at all, and we've had quite a few children who are really iron deficient and have iron deficiency, serious iron deficiency anemias. So I would order the nutritional bloods and full blood count and iron studies and vitamin D. We've had so many children with very low vitamin D, and I know you can make a case for it's so difficult to get blood from a child, so if we're taking the blood, we may as well take everything else. And there's a case to be made for that, I suppose. It's just when it comes back, if it comes back abnormal,
what are you going to do with it?
Well, you can just refer.
I guess
refer to a paediatrician or refer to even our department. We manage what's called the variant of uncertain significance ourselves. We would just get the parents to do a blood test and see if it's a familial variant, which it often is, but really for everything else we are referring to quaternary services like the genetics department at RPA. So that's the local genetics department, which don't even ask, there's a wait list for the wait list letters to go out. I've never heard of anything like that. But there are private genetic specialists, so if families want to pay, you can get in quite quickly. So that's what we do, because families need quite detailed counselling. They're often planning further children, or they have many questions that even we are not skilled enough to do. So I do not think it's the GP's role is the end, apart from ordering nutritional blood. Take a dietary history and order just the relevant nutritional bloods. You'll probably get a surprise because there's so much iron deficiency out there. So always order iron studies with the full blood count.
Thank you. There's another question I can see, and
thank you, Jackie and Martina. There is one more question just came through. Is the concern when a child walks on tiptoes?
So walking on tiptoes is what we here in the trade call a soft neurological sign. So it's very so when it's associated with a global developmental delay or autism, we would do a general full physical examination. If there were no other neurological problems, we actually refer them to our physio, who puts them in heavier shoes, frankly. I guess the only thing you're looking for cerebral palsy or something like that. So just a full neurological examination, and if you're not sure, refer to a specialist. that's what they're there for. But it's very commonly associated with children with developmental problems. We don't know why. We just don't know why they do it. They do have tight tendo Achilles, but it's sort of a chicken and egg thing. We're not quite sure whether walking on the tiptoes has made their Achilles tendons tight or the other way around. So the treatment is usually putting them in firmer shoes and stretching exercises. They still tend to walk on their toes. But it is a soft sign that's associated with developmental delay.
All right, I've got one more case study to do, so we might go back and finish that off because we've still got a little bit of time, if that's all right for people. So this, I'm hoping everyone can see this. This is Jay, age 3. So he's brought in by his parent because he's got urge symptoms. But you notice that he seems a little bit clumsy, and you ask the mother, how's he going? Does he have any problems? And she reports that he falls over a lot, doesn't play as well in the playground as other children of his age. And if we had a lot of people on the panel, we could talk it through, but I would be hoping that one of the things you could do using health pathways would be to open, because I presume the mother hasn't bought the blue book because it's not a regular checkup and Jay hasn't come in for an immunisation. So you could use health pathways to go to the milestones page and click on the milestones for a 3-year-old to see what they should be doing. And what you would find is they should be able to run and climb and go steps one by one without too much trouble. And so a child that isn't comfortable in the playground and falling over a lot may well have a reason for doing a further developmental screen. And so you might then arrange for an ages and stages questionnaire to see if there are other things happening. But you'll also check the other milestones yourself just by looking at the, See the Signs Act Early checklist for a 3-year-old. And then you can access your developmental concerns in children to have a think about what else you could do. Jackie, how would you approach this patient?
I'm just having a think. We don't see them at this stage.
Well, that's true, isn't it?
The benefit of the GP having decided it's a concern. So look, I usually for his. So look, they've come in for the urgy symptoms. There's probably not going to be much time to ask a lot of questions.
Mm-hmm.
So I would just ask a little bit more about it. How long has that been for? How does he get along with children, other children his age? What's his speech like? Just a few quick questions like that. And that's probably going to give you a fair idea of where to go with that. And if you feel that there's a problem, just even from those few quick questions, I'd actually suggest, just as you've suggested, it'd be really good to bring him in for another appointment so we could have a bit more of a talk about his development and what he's saying and doing. And that would be an opportunity to do a screening assessment as well. I'd ask whether, that's, and then make a decision after that. I do a physical examination. I would actually check vision. Vision is a not uncommon thing for children to fall over a lot. And I think my main message is I actually don't think it's the GP's problem to do the worrying. I think it's our problem to do the worrying. And I think if you're worried at all, you should refer. I'm probably not going to be thanked in my department for inviting a lot more referrals, but I think it's true. I think
I chose this
to identify the concern and do a bit of a screening questionnaire and just get a little bit of a screening history. That's it. And it does become clear when you see the child. So I haven't got much more there to go on. So.
No, that's fine. And I was deliberately not giving you a lot because Because if you assess this child and you do their other milestones and they're not falling behind in any other milestones other than they seem a little bit clumsy, then they, you know, after you, I would bring them back for further assessment.
Yep.
And then once I'm satisfied that, you know, their speech is coming along and
Absolutely.
other things, then you're thinking, okay, well, this is a single domain. And so I'm going to use my allied health contacts. Maybe I'm going to do a GP management plan because I'm going to ask for an OT assessment and maybe a physio assessment and see if they and some intervention to see if that can bring them up to speed, and then bring them back and follow them up. And if you discover that other domains are affected, that's when you start thinking about a referral to community paediatrics. But we can manage a lot of things ourselves. Obviously, with the GP management plan, there needs to be 2 other health professionals involved. I know that. And it only gives 5 sessions, but it gives them a start.
Yep.
And I think that's really helpful. But of course, if you brought this same child back and discovered that they had also problems with social and with speech, then you're starting to get concerned. And we can start using health pathways or using our knowledge of community resources. We can organise for optometry assessment and audiology assessment, and, you know, start putting the picture together with the parents so we can start working out what's going on, and hopefully that will point us in directions that we can start chipping away at while they're on that very long waiting list for community paediatrics. So yeah, I'm hoping that that's helpful. And that you'll find going to health pathways can help you gather your thoughts and start to think about how you can assist the family negotiate the system. Just to finish off my talk, I wanted to let you know that there are general practice colleague referral pathways for Southeastern Sydney health pathways. And so we are seeking nominations, asking you to nominate yourself if you have particular interests in these clinical areas that are listed, and if you're happy to provide care to patients just for this particular area in collaboration with other GPs in the area who might not have a specialty niche area like this. So if you want to nominate yourself, you can contact Sue Baker, our project officer, or use the feedback icon at the bottom of the GP colleague referral page to nominate yourself. And I also wanted to give you the contact details of both Health Pathways teams. Lydia, I will send you a copy of this, so if people want to get those contact details, they'll be able to find it from the PowerPoint. But on each pathway also, you're able to send feedback to the Health Pathways team using the blue coloured feedback icon at the bottom of the page. Thank you. That is the end of my presentation too.
Thank you very much, Dr. Jackie Pollock, Dr. Martina Gleason. Thank you for your insightful presentations and for the panel discussion. And to conclude tonight's activity, I would like to invite a colleague of mine from CESPN, Hannah Coffey, who is Intellectual Disability Educator and Project Coordinator at Population Health and Chronic Disease, a team to introduce Project Grow. Thank you.
Thanks, Lydia. I'm just going to share my screen. If you could let me know whether you can see that clearly. Can you see
Yes,
that?
thank you.
Okay, fantastic. So hi everyone, and thanks for all being here tonight. I'll be quite quick because I know it's the end of the evening. As Lydia mentioned, I'm here to introduce the PHN's Primary Care Enhancement Program, or Project Grow. You may have seen some communications going around about this project, and I guess it fits in nicely with the content from tonight's presentations. The Primary Care Enhancement Project is a 4-year federal government funded pilot program. 4 PHNs in Australia have received this funding, and our primary goal is to improve healthcare and health outcomes for people with intellectual disability. Some of you may be well aware of these statistics, so I'm not going to go through all of them. However, they are important and a little bit frightening. Currently, people with intellectual disability are up to 4.5 times more likely to be hospitalised for conditions that could be managed in primary care settings. And in New South Wales, the leading factor of increased mortality among people with intellectual disability is preventable health conditions that have been misdiagnosed or poorly managed. These are some of the contributing factors that lead to people with intellectual disability having a life expectancy of 27 years less than the general population. So why is this information relevant to tonight's presentations? Because it's now pretty well understood that morbidity often emerges in a paediatric period. A number of health issues start during childhood and continue through to adulthood, where evidence suggests it's harder to have an impact on preventative health behaviours, and there are more barriers that impact effective health interventions. So let's quickly reflect on disability and health. Disability for a long time has not necessarily been seen as a health issue, and there are many system barriers that limit the integration, I guess. We know adults with intellectual disability have high health needs across a range of areas: mental health, respiratory health, neuropsychiatric conditions. They have elevated markers for premature aging, and they can have a range of issues with their gastrointestinal systems. Despite this knowledge, and during the paediatric period especially, and as we've talked about that tonight, families are often much more focused on the developmental outcomes rather than health outcomes. To shift the outlook for adults, there's a really key opportunity to address some issues in the childhood period by including discussions about health early on. The involvement of GPs throughout the diagnostic phase of a child presenting with developmental delays is just as important as GP involvement in the long-term management phase, with health promotion and surveillance. And GPs are one of the core components for ongoing positive health outcomes. It's really important to spend time building a relationship with these patients and exposing them to clinical scenarios in a range of different ways from early on. This includes immunisations, ear checks, blood pressure checks, annual health assessments and oral health assessments, planned visits as well as unplanned visits if issues arise. Just because a child or an adult, for that matter, is receiving care under a tertiary service, the GP still has a crucial role to play. An individual might not be experiencing poor health currently, but we know that they are at high risk of it, and it's important to get them used to these checks as a child. So when the risk heightens in adulthood, they are used to the interactions with you as their clinician. The goal for a child with an intellectual disability is to transition out of the paediatric period with a GP who they are well known to and who is able to confidently manage their health needs and lead them into appropriate adult services. So that all sounds well and good. However, we know that there are numerous barriers to delivering effective healthcare to this population, and this is where our program's coming in. We're working with primary care providers as well as community members, organisations and disability service providers to ensure people with intellectual disability, their families and carers, know how to seek healthcare, when, where and at what level. We want to ensure patients and their family members have a good understanding of the role of GPs, and also to support GPs to provide effective care and easily access referral pathways when necessary. It would be lovely if a patient with intellectual disability turned up on time to every appointment that they had, unagitated, because they were booked in during a dedicated sensory period in that practice where lights were dimmed and the waiting rooms were quiet. It'd be great if the patient or their support person brought all of their relevant documentation. You received their recent hospital discharge summary to your inbox, as well as Jackie's discharge letter that she saw after she saw that patient last week. It'd be great if the patient was able to clearly communicate where their pain was and discomfort was, when it started, what makes it worse, and then they could jump on the bed for a thorough examination. It'd be great if you had an hour for that consultation and then an extra 15 minutes to document, and then time to look at referral pathways, maybe find a suitable dietitian in the area that specialises in intellectual disability and fill out a relevant referral form. We know that this isn't the case. So how do practices implement effective care models with necessary reasonable adjustments when practice resources are already stretched? We know that the Medicare funding structure does not provide effective financial remuneration for the extended consultations that are often required for this patient cohort. What we do know is that it can be done. What does an effective model of primary care look like for someone with intellectual disability? That depends on the individual, their healthcare requirements, and the way your practice functions. There's no one-size-fits-all approach to this population. Whenever we're engaging with someone with intellectual disability, I always like asking them what their general does to remind them about an upcoming appointment. The answers are wide-ranging. Some say automated text messages work for them. Others prefer a letter in the mail. Some say they rip up every piece of mail they receive because they can't read, and text messages are useless. So they rely on a receptionist at their practice to call them the day before their appointment. What we know is if you take a preventative healthcare approach with strong continuity of care, risks can be identified early and appropriate interventions provided. So our GROW service navigators are providing tailored support to implement solutions that result in efficient work practices that are financially viable through effective utilisation of MBS item numbers, increase staff enthusiasm, and most importantly, improve health outcomes for your patients with intellectual disability. There are practices that are doing this really well, and your practices may be some of them. The strategies used are really varied, and we're hearing about more every week. Some build in reminders to practice software for annual health assessments, chronic disease management plans and plan reviews, mental health assessments, cancer screenings. Others implement tools such as TopBar that link to specific diagnosis and relevant interventions. Some have systems to ensure that every patient with an intellectual disability or is deemed vulnerable or at risk of slipping through the cracks always has a follow-up appointment booked. And if an appointment is cancelled, there are strategies in place to follow up that patient. We know some practices use Excel spreadsheets to keep a registry of these patients with relevant interventions clearly mapped out, and due dates and strategies for recall reminders. The involvement of practice nurses, as we've talked about tonight, as well as telehealth consultations, can be really effective for this patient cohort, especially with preventative health interventions and to build that rapport. We have filtered through the endless number of resources, training materials, patient resources, and clinician resources to ensure that what is being provided to you is relevant and is useful. And we're working across all primary care disciplines and with tertiary health services to improve access and coordination of care. In addition to this, our team is also delivering a clinical CPD calendar in partnership with the local health district specialist intellectual disability health teams. These sessions are RACGP accredited with topics based on feedback we receive or requests by clinicians. To date, this has included oral health and dietetics, CPD events. We have a scheduled genetic screening and delivering a diagnosis with unbiased language CPD events. We're planning a consent and supported decision-making event. This is in addition to our quarterly general intellectual disability healthcare CPD sessions, one we run next month. So I guess I'll leave you tonight with a couple of actions. If you're interested in any of the content, if it resonates with you at all, please register your interest in having one of our service navigators come out to your practice. We're working with practice managers, GPs, practice nurses, as well as admin staff to support a solution that works for you and your practice. There's a QR code down the bottom or a link, and I'll send these slides around as well if you're interested. I'm also providing a link for our upcoming CPD event scheduled for June 15th. This is our general intellectual disability healthcare event. There are RACGP points accredited for this event. If you'd like any further information or would like to subscribe to our quarterly newsletter, which provides a spotlight of new and relevant regional services, as well as an overview of relevant updates, please get in contact with the team. And I'll leave it there.